Hello, my name is Melinda Grabman. I did my evidence-based practice research on infection prevention in acute care settings. Infection prevention and decreasing the spread of pathogens is imperative to patient safety. According to Snyder and Pearl, HAIs increase morbidity, mortality, cost, and length of stay in a hospital. Hand washing, wearing personal protective equipment, and decontamination of equipment are all important aspects of HAI prevention. Hospital-acquired infections are preventable, yet they remain a vast issue within healthcare. Hand washing and infection prevention is imperative to improve patient outcomes, improve patient satisfaction, decrease cost, and save lives. Preventing harm to patients is a key component of healthcare. Approximately 90,000 people die each year due to preventable hospital-acquired infections. Also, in the United States alone, almost 2 million HAIs occur annually. Hand washing is the #1 most effective method in preventing the spread of infections. According to Jacobs, the link between hand washing and infection control was made by a Hungarian physician more than 165 years ago. This Hungarian physician detected the variance in mortality between two clinics within a maternity hospital. His theory was that medical personnel were transmitting pathogens from cadavers to obstetric patients and their babies. Along with hand washing, wearing personal protective equipment in an acute care facility is also important. The purpose of this study is to link the association of evidence-based practice that decreases the spread of infection. Question: in acute care settings, what is the effect of hospital-acquired infections when hand washing, personal protective equipment, and proper infection prevention is consistently used? Research was collected from 8 quasi-experimental and randomized control trials. Various aspects of preventing HAIs were reviewed. Almost all of the studies linked active surveillance of infection prevention and education to a decrease in the spread of nosocomial infections. Several techniques were studied with the ultimate goal of decreasing the spread of HAIs. Data was collected by using the James Madison University Library databases. All information was collected from sources published within the past 5 years. Some of the following mesh terms and keywords include hand hygiene, nosocomial infection, health screening, hand washing, infection, control, contact precautions, adult, hospitals, surgical wound, and humans. One quasi-experimental study was completed in 5 different countries regarding hand hygiene practices in acute care hospitals. The study found that education on hand hygiene does affect compliance. Also, after implementation of the World Health Organization's hand hygiene strategy, the study noted hand hygiene practices increased. Another quasi-experimental study was conducted in a NICU of a tertiary care facility. A comparison of incident rates and statistical analysis was conducted to measure the results. The end result concluded that hand hygiene compliance after education showed a decrease in infection rates and improved hand hygiene. Another quasi-experimental study was done at a 637-bed tertiary care facility in Canada. A multivariate analysis was performed in correlation of location of sinks and hand hygiene practices of staff with C. diff patients. The conclusion was that the further the sink was away from the patient, the less compliance staff had for hand hygiene. Another study was completed in an acute care facility involving the initiation of contact precautions after confirmed urine cultures of E. coli or Klebsiella. This study held inconclusive data due to urine culture's growth time and the high prevalence of cases in the community. There was no confirmation of decreased nosocomial infections with this study. A randomized trial was completed using several acute care facilities. It analyzed the leadership and social influence and the effects they had on hand hygiene practices. Questionnaires, observations, and other data resources were used. The conclusion of this study was that hand hygiene practices are affected by leadership and can have a negative or positive impact. Another quasi-experimental study evaluated 26,180 ICU admissions. Analysis was completed of the use of chlorhexidine wipes in correlation with personal protective equipment. MRSA swabs were completed at admission and discharge. The conclusion was that chlorhexidine wipes used along with personal protective equipment decreases infection rates. Also, the use of active surveillance to enforce infection prevention shows a decrease in the spread of infection as well. Pissarro 2016 completed a randomized controlled trial using ICU and general hospital patients, non-ventilator associated. Oral mouth care rinse with chlorhexidine applications were used along with standard precautions. The conclusion was that proper oral hygiene decreases the occurrence of hospital-acquired pneumonia. It was also noted that preventative measures and surveillance of infection control decreased the amount of infection rates. Another trial was completed using surgical orthopedic patients. This study followed each patient for a year with an average of 40 microbiological tests. MRSA was the most commonly diagnosed bacteria during the trial. It was noted that surveillance and enforcing infection prevention protocol decreases the spread of infection. In conclusion, evidence presented from various studies links education and closer surveillance of hand hygiene practices to a decrease in the spread of nosocomial infections. Proper hand hygiene practices using standard precautions in correlation with wearing personal protective equipment and other infection prevention practices decreases the spread of infection as well. And these are my references.